Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. And we are about to talk about antiphospholipid antibody syndrome. Paul, you know all about this before this episode, right? Super
There are a
easy.
few things I feel more comfortable with than antiphospholipid syndrome. I felt like a master before this episode and maybe marginally better afterwards.
I wanted to do this episode for a long time because, you come across antiphospholipid antibodies a lot because they can be present in patients who don't have the syndrome. Like, so when you test people for antiphospholipid antibodies, sometimes you find them even in a person who doesn't have clotting. And that's because the people can develop these antibodies, but it's hard to know which people that have the antibodies are going to have a clot, because they have to both have the antibodies, and the antibodies have to be able to activate the clotting cascade. But we don't yet have testing to say who can do that until they've had an event.
Yeah.
So, Paul, which groups are people where we should, or where are times where we should suspect antiphospholipid antibody syndrome and send the testing?
Right. Yeah. So I think most of the time now, a lot of times when I see these sort of ambiguously positive tests is in patients where it's part of an order set and they sort of knee-jerk order, and then something comes back and you're like, well, now what do I do with this? So rather than doing that, our suggestion to you is to do more directed testing for the people that actually you should have high suspicion for. So those people would be folks that have arterial clotting without atherosclerosis, particularly in younger patients where that would be unusual. Clotting, despite appropriate anticoagulation that they're already on. So if they're somehow overcome anticoagulation for reasons that are unclear, that's someone to think about. I think a really important one that often gets missed is venous clotting in unusual sites, and particularly splanchnic clots are also, I think, intracerebral clotting, venous clots too. It should prompt suspicion for antiphospholipid because you should not be clotting there. And
Right.
then if you also have a history of autoimmunity, specifically lupus is the one I think we all classically think about, but not necessarily just lupus, and someone with a clot, that should also prompt testing as well.
Yeah, and the criteria are there were recent criteria in 2023 release, but they are very research heavy. And what our expert recommended to us is to continue to use the revised Sapporo criteria, which basically there's a clinical component. So you have to have arterial or venous clotting, plus you have to have at least one of the lupus anticoagulant, beta 2 glycoprotein, or anticardiolipin antibodies. And if you have any one of those three and a clot, then you again have to test them 12 weeks later, Paul, because just inflammation in the body can cause you to get some transient positivity to some of these tests. There can be false positives. So it has to remain positive at 12 weeks for you to know. And usually you want to see the titers of the antibodies above 40 to think it's like a real thing. Between 20 and 40 is a little bit of an ambiguous
Yeah.
range. And if you had your druthers, you would always want to test the lupus anticoagulant before they start any kind of blood thinner, because once they're on a blood thinner, it becomes much more difficult to interpret the test.
Yeah, and I think it's a rare occasion where you'd stop anticoagulation solely for the purpose of checking that level after the fact. I think that's exactly right. Once that river's been crossed, you're kind of stuck there.
So, Paul, what about the treatment for this? Can we use DOACs? What's the deal?
What's the deal with DOACs? Yeah, I think the first line treatment is going to be warfarin, Matt. It's old school. I think people are becoming increasingly terrified of it as people are less familiar with it. But it's what we got with an INR goal, specifically between 2 and 3. Our guest made the point that there's not many folks that had that. So the studies that have looked at this, like, we just don't have a lot of data. So for right now, she aims for 2 to 3 because there has not been benefit seen at higher goals. With DOACs, there has been risk for recurrent clots seen on those compared to warfarin in a couple of studies. And so, it's regardless of whether you have the so-called single, double, triple positivity. So you do warfarin unless she mentioned that patients who are low risk, who just absolutely don't want to be on warfarin, maybe you can consider a DOAC and still not feel great about it. But for the most part, it's going to be warfarin therapy for these patients.
Yeah. And this is this condition, if they have antiphospholipid antibody syndrome, and they are high risk for clotting. They should absolutely be bridged when they're going for surgical procedures. And Dr. Langer made the point that she wants to be involved. You should involve the patient's hematologist if they're going for a surgical procedure to make sure it's done correctly. And, it can't be like it can't be a bridge where things don't happen the way they need to, which you a lot of the times when you try to bridge somebody, it doesn't go smoothly. So this is one where you need it to go smoothly because these people are really at high risk.
Yeah, she made the point. Even if you do it perfectly, your hematologist is going to be lightly annoyed at you if they're not involved in the decision making process. So just give your friendly neighborhood hematologist a call.
So this was an extensive episode. We also talked about obstetric antiphospholipid antibody syndrome, which we can't get into on this video, but lots of great pearls in this from a fantastic guest. So if you're interested in hearing more, please click on the link in the transcription below. And with all that, until next time, I've been Dr. Matthew Frank Watto, bringing you a little knowledge food for your brain hole.
I think I've referenced Rachel Ray before at this point in your spiel. Have I? Do you remember her? She
I
used
don't
to say
remember
Yummo.
that.
Rachel Ray. Anyway, it doesn't really matter. But yeah, carry on.
Are you going to, I signed off. Are you going to sign off?
Yeah, sure. I'm Paul Williams. Thanks. Have a good night.